subcommittee were able to work on when it deals with reproductive health and fertility for women with sickle cell disease. And we'll start with the fertility survey. Of course, my group already kind of had the highlight of this already, the privilege. But the goal and purpose for this survey was to kind of get an understanding and education on what the patients, how they felt, their perspective, what they thought was lacking, what they was frustrated about, what they wanted more knowledge about, more education about. And so it was a very quick survey that took about a minute for them to complete, and this was actually at different sites. It was a very small sample size, but it highlighted a couple of things that I wanted to discuss. So 30% of those patients that underwent transplant or curative therapy options with gene therapy, 30% were able to move forward with fertility preservation prior to transplant. 70% of those patients were not, and the main barrier was cost. And then for the research publication clinical care subcommittees, I co-chair with Neha. And so we also found that 90% of those individuals received fertility education. 80% was very satisfied with the education. The majority of those participants received education from their fertility specialist or their transplant team. But what was interesting that stood out was that majority of all those patients had not received fertility education prior to transplant. So there was a lot of questions and a lot of emotions from patients when they had those fertility meetings or was told information that was not very forthcoming for them. And then for administration post-transplant, 20% of the population restarted their menstruation. 9% of those patients actually required hormonal therapy replacement. And then we noticed that we wanted to look at the age of when they first had their menstrual cycle, and a lot of those individuals was 12 years of age or younger. We had a couple that may have been within that 13 to 15 age range, but it seems like the ones that had a menstruation younger was able to have their restart their menstrual cycle. And then these patients also was age-wise was a lot younger too than the older patients. So they ranged in age from 22 to about 19 to 26, and those who were older had not really restarted their menstrual cycle. And then we also worked on a joint project that kind of assisted with the clinician education documents for providers who take care of women and girls with sickle cell disease. Is this you guys, right? So I'm gonna pause here. But I did want to say that some of our future planning that I thought was very intrigued for our subcommittee was that we wanted to do more education on perimenopausal, like who actually will work on perimenopausal education, who should actually manage the perimenopausal. We also wanted to do a lot of education about with adolescent young adults, just all in general, how to improve knowledge when it comes to family planning versus curative therapy. What does the patient think? Have a survey made more so from the patient's perspective and gain more insight for those patients to say, hey, how do you prioritize, how do you want to prioritize your care, whether it's, do I want to move forward with curative therapy? Do I want to continue hydroxyurea? When do I want to start family planning? Having these conversations early on might be more effective and efficient, and for those patients to actually move forward with family planning. And then I think one future study I think that stood out, and I'm going to wrap it up, was that maybe there are different practices that are all the different sites have different practices of how they manage and treat women with that are childbearing age. So whether these individuals are male or females, whether these individuals are being taken off of hydroxyurea, whether they're going to continue hydroxyurea during pregnancy, when do you restart it, just having that collaboration of understanding how do you actually manage these individuals, women with sickle cell disease, when it comes to family planning. So I think maybe having a survey that kind of go out to all the providers at different sites to understand your commonalities in practices and then your variations as well. And then maybe we can work together and come up with a combined effort of how we want to unify our approach. All right, that's it. I said I'd go through it very quickly.
Okay, hello, I'm Kemi Olaya. I'm one of the co-chairs of the subcommittee, the Education and Advocacy Subcommittee.
Hi, I'm Cheryl Mensa, the other co-chair on the committee.
So this year, over the past year, we collaborated with the Research and the Publications Committee, as well as Nancy Sakari from the Thrombosis Subcommittee. It was a lot of work, a lot of team effort to develop this clinician educational document for providers that care for women and girls with sickle cell disease. It has, and I believe that there are copies out there that you all can take a look at. It's just really a primer to help you kind of start conversations with patients when you see them in the clinical setting. Oh. Am I doing this right? There it goes. Okay, and part of the document also includes information about hormonal therapy options, both that can be used, that can be provided to patients as well as the providers, that looks at the different considerations in patients with sickle cell disease, so heavy menstrual bleeding, VOC, impact on thromboembolism as well. Some of the other work that we did is we had a webinar, Women with Sickle Cell Disease, Reproductive Health Matters, that was in September, and we worked with Cheryl, obviously, who's right here, as well as Bria Carruthers-Taye and Nancy Sakari, and we had really great feedback. I think it was, well received, and you are able to access that through the FWGBD website. All right, and then in addition to that, so we talked about some of the completed projects, the webinar, the document, and then we also worked with Leslie Apia and had a podcast on the 721 podcast, which is a great podcast, and we discussed fertility preservation. And that was episode 1. Episode 2 was kind of additional information about fertility preservation. So take a listen, if you haven't, to all the episodes on the podcast, but especially these 2.
So also, we did have an oral abstract that was accepted to SCDAA and was presented on Friday. It was a scoping review on contraception in sickle cell disease. We have an upcoming presentation with Dr. Sakari, Dr. Carruthers-Taye, Kemi, and myself at NASPAC, which is the World Congress Pediatric Adolescent Gynecology Conference in April. It will be a panel on basically reproductive health and sickle cell disease for the pediatric gynecology providers. Our next steps, which we also discussed at our breakout meetings, we have, we're pretty ambitious, but we do want to work on a document on transformative therapies, and perhaps we could collaborate with Karina's committee. But our goal is to create a document to educate hematologists and other providers about what to be aware of and implement for patients who are undergoing transformative therapies and their family planning, and especially fertility preservation. We also, during the webinar that we did, there was a survey on provider knowledge and attitudes about reproductive health. So we will do like an analysis and then also potentially publish those results. And then lastly, in the breakout session, we talked extensively about bone health and sickle cell disease and hormonal therapies. And the goal, well, we have 2 potential goals. One goal is to make a document for providers, and the other is actually do a study on bone health and sickle cell disease and hormonal therapy. And then we did discuss also extensively about advocacy for sickle cell trait testing. Even though there's newborn screening, about how to improve access for providers to find that newborn screening, for patients to find access for themselves. And we also discussed, I think we also discussed like a video too, to basically help empower patients and their caregivers about, the importance of sickle cell trait testing and newborn screening, especially in their family planning process. And then lastly, we're working on a lifespan health paper. And so the whole subcommittee meets every month on Wednesdays or Thursdays alternating, but we meet every 2 weeks, and we're making a lifespan health paper on what a provider should know about reproductive health for a patient, beginning from, from the beginning, from like early childhood to post-reproduction. Things with, contraception, pregnancy, and even like HRT. And so we welcome everybody to, participate and to join. Yes. Thank you.
So we don't have a slide to show you all. We'll just present off the cuff like we like to do. And take it away, our program development.
Hello again. So we had a great discussion, small group. It sounds like this is a new addition to the program this year, but I think really important. So we had our Dr. Jacob and I, representative from Innovative Hematology, people from Utah, as well as Nationwide Toledo, and then of course Dr. Nero. So the sort of problems we defined were access to care, lack of cohesion or shared systems, and people having ownership of that care to ensure access and addressing the problems that ensure quality improvement. And really trying to focus on the principle of you're not alone, trying to build communities, build relationships, build spaces where we can learn from each other and feel supported. Because we acknowledge that burnout is a huge problem, particularly in people that are sort of trying to develop new programs, trying to work in spaces with very little resources. It's a very isolating, very demoralizing. So really wanted to try to build spaces where you can feel supported and acknowledge that we're all dealing with the same problems. 30 patients, 2,000 patients, a lot of the problems are really the same. And that we can work through those problems together, both having a community on a national level, but also encouraging people to build local communities as well. That there are ED docs and hospitalists and primary care docs who are also dealing with these same struggles, and that there's a lot of value in creating spaces where you can sort of feel a community that's supporting you. Sure.
Okay, so with that background, then we tried to kind of dig in and see how we could make this tangible and have some takeaway action items to move forward. One of the first things that we talked about was addressing the lack of physician interest, particularly in adult care, part of which we talked about identifying our regional partners and people in the local community near the centers. So where we have places where people are doing the work and then people who are not doing the work that are nearby, how can we get more engagement and support to kind of distribute the care and teach more people how to do competent sickle cell care? We talked about the trainee bias in experience, and we learned that in training very early on, people are discouraged from doing hematology. So classical hematology is not encouraged in hemonc, it's do oncology. And then moving further, definitely don't do sickle cell care, right? So can we get people earlier by creating learning environments and mentorship? Yesterday, mentorship was discussed, and so we talked about mentorships and projects that would, that we think could maybe help encourage and break the bias and stigma that's happening very early, even before fellowship. And then we talked about, creating more resources through the foundation and this group, this LAN, that can be available to everybody. So the people who care can find the information, but maybe condensing and pulling some of the existing things, so we don't want to reinvent the wheel. And again, we want to make respectful partnerships. So to do this, some of the goals we came for tangible next steps would be, one, on the site is to pull the links that exist. So do our research and pull the relevant links from places like things like ASH. A lot of people are joining the National Alliance, which is creating some of these communities, so having resources there. Dr. O'Brien will help us research some of the takeaways, even though they're no longer, ASH is no longer doing the Sickle Cell Center's workshop, but what's available to have, so when people do hit, do they have something they can learn from in developing this? Also leveraging the ECHO programs, and again, getting the information on what we call it, the Sickle Cell Survival Toolkit page for your developing center. When we talked about the mentor-mentee relationships, we talked about the student, resident, and fellow level. And so we propose a first step of identifying from this group people who would want to be a mentor to someone, and then putting out like small grants or funding to get engagement at these levels of training so we can get that early exposure and love for sickle cell care while we're building the next generation of hematologists and specialists to take care of sickle cell patients. Towards the end, we also talked about, all the things that you need to have, the good sickle cell care. Before you can develop your women's clinic, you need a place to take care of any sickle cell patient, and all the staff that's needed. And so also to look into non-physician team members, where are those supports? So we talked about some of the organizations like IAN SCNAPA, but we know social workers, nursing, other groups also need help because they're part of this team, and some of them may have never seen or done sickle cell care, and also keeping them as active, engaged members of the team. So also looking for our non-physician team members, ways that they can also feel support and internal mentorship from their level of training, their license. And so those were some of the proposed next step that we have developed for this. Thank you.